Welcome everybody to the BMT sessions at in the Shaukat Khanum Cancer Hospital Cancer Symposium. My name is Dr. Syed Waqas Bukhari. I'm one of the consultant hematologists at Shaukat Hospital. Myself and my colleague, Dr. Bushra Hassan, will be moderating this session. We have four very interesting talks by four distinguished speakers joining us from all over the world. The first talk, the opening talk, is on the role of acute leukemia, stem cell transplant in acute myeloid leukemia by Dr. Shaukat Hashmi, who will be joining us from Abu Dhabi. One down will be Dr. Kasser Bashir, joining us from the US, and he'll be talking about haploidentical hematopoietic stem cell transplantation. He will be followed by Dr. Saira Ahmed, again joining us from the US. Her presentation will be on how to approach graft versus host disease. And finally, last but not least, will be Brigadier Dr. Kamrun Nisa Chaudhry from Armed Forces BMT Center, Rawalpindi, here in Pakistan. And she'll be talking about autologous transplantation in multiple myeloma. So at the end, we will take all the questions and we'll have a question and answer session moderated by Dr. Bushra Hassan. Without much ado, I would like to invite Dr. Shaukat Hashmi for his presentation. Dr. Shaukat is a consultant and chair of hematology and oncology at Sheikh Shakbout Medical City in Abu Dhabi, UAE. And we're delighted to have him join us. Dr. Shaukat, please kindly share your presentation and unmute yourself. Thank you.
Sure, thank you very much. Delighted to be here, and I hope I'll be able to share my screen successfully, and I'm hoping you can see my screen now.
Yes, we can. Do you mind going on the slideshow?
Yeah, I just put in the slideshow right now. It's on the slideshow mode right now on my computer.
Okay, so I can. I don't think we have the slideshow showing on our end yet, but it might come through soon.
Okay, so let me just click on the. I just came out, and I'm just going to click the slideshow again. Okay, so now, can you see the slideshow?
Yeah, we can.
All right, perfect. Thank you very much. And without further ado, I'm going to just go ahead. I have no relevant conflicts of interest, many disclosures which are here. So today what we're going to talk about is just basic transplant activity, understanding the prognosis of AML, understanding the eligibility for transplant, and appreciate the real world issues in bone marrow transplantation for AML. Patient-centered holistic care is something that I'm going to talk about in detail as we go through. So a little bit fast statistics on allo and autos. Currently in the world, 70,000 transplants happen annually, hematopoietic stem cell transplants only. About half of these are allogeneic, and as you know, in developing countries, allogeneic are predominant transplants, unlike US and Europe, where the autologous transplants are the biggest chunk. In the United States, 24,000 transplants occurring annually. We're treating more than 50 conditions for transplantation. Number one indication for US for allogeneic transplantation is AML, although this is not the biggest indication for overall transplant, which is myeloma currently. Transplant rate mortality of allogeneic transplants has significantly improved to 20%, which is still the highest mortality of an elective procedure on earth, but it's come far down compared to earlier times. This is recent data from the world. It does not account for subgroup data. As you can see, transplant activity increases for allogeneic and autologous transplants. the allogeneic transplants have increased, and the dark blue line that you're seeing is actually the unrelated donors, and we have a 40 million people registry currently worldwide, which filters from WMDA, which filters from the Anthony Nolan and NMDP and other registries. But the orange one is the haploidentical transplants, which are tremendously increasing. I don't want to steal the thunder of Dr. Kasser Bashir, who's going to be talking about this in detail. This is by disease, and as you can see, the greatest increase in activity for the transplant activity has been AML. That's the topic given to me, and other diseases are increasing as well. In fact, some of them may not be increasing. Lymphomas are going down actually in 2020 because of CAR T cells, but AML continues to significantly increase, in fact, for the haploidentical transplants in the United States. The trends in AML, as you can see, all age groups are increasing, especially the elderly, as well as over the past, this millennia, the 40 to 60 group has increased significantly as well. This is US data only by CIBMTR. And early stage, intermediate stage, advanced stage, there's increase in early stage AML because greater availability of donors, increased transplant activity all over the world, haploidentical transplants, many other reasons. And as you can see by donor type, the unrelated activity has increased, and the green bar here is actually the haploidentical transplants. So the topic is very interesting because what constitutes the bulk of AML transplants is a combination of many factors. And if we think that genetics is the most important driver of the transplant activity and should be the driver, then we are at fault, because it's not the genetics only, it's all the other factors that I enlist here: remission status, genetics, patient suitability, age of the host, expertise, availability, financial resources, access to care, and family support. So all of these things actually do play a role in transplant, equally important to the genetics of AML. And the real world data is actually showing the reason why all these factors play a role. Let me spend a couple of minutes on this slide because this is considered to be the one of the basis of the typing or grouping of the AML based on the genetics of the disease. Now, I'm going to give out some practical aspects. This was published 3 years ago by ELN, and this is considered the gold standard for the classification of AML for prognosis, because some of them, which are given adverse features, like you get the DECNUP mutation, translocation 6-9, extremely poor prognosis. You've got to transplant them in CR1. Same thing with KMT2A rearrangement. That's actually looking at the 11q23 itself. Now, it's interesting that if you get this result in real world, KMT2A mutation on NGS panel, actually you're looking at the MLLT3 KMT2A mutation as well at the same time, but that's actually translocation 921. You've got to look into the details. So when a patient comes to me for transplant, this is, and I've been doing only allogeneic transplants, as all of you know, the past 10 years, and I tell the physicians that when you refer a patient to me, I need to have the cytogenetics, the FISH panel, and the NGS panel ideally as well, or some kind of mutation profile, as well as the morphology and other factors as well before you refer. And if you don't have those, it's better to do them properly and then send the patient for transplant, or at least try your level best to get them again if the first time karyotyping failed. Because when I was at Mayo Clinic for many years, and I still work there part-time, we never got anything less than 20 karyotypes. But in real world, getting a FISH, NGS, and cytogenetics is not easy, in fact. And a lot of people don't come with all three. Majority actually do not come with everything, the information I need for a bone marrow transplant, yes or no. Given the high mortality, one needs to know these things. Now, favorable is the only group in 2020, which actually in CR1, in selected cases, you can just do consolidation chemotherapy, and you not necessarily need to refer for transplantation. But should you refer all AMLs for transplantation if all of the factors besides genetics of the cancer are met, like young age or middle age, as well as financial suitability and their excellent baseline health? The answer is yes, because they need HLA typing. Even if you have NPM1 mutated without FLT3, you actually would refer them because you would get the HLA, basic HLA typing, and as well as some understanding of the family members for typing as well. Because if they relapse, the favorable group in CR2, they need a transplant too. So that's the reason why this slide actually could be misleading to a beginner because they're focusing on what to transplant, what not to transplant, and they're really confused about the intermediate. In my mind, obviously, if this was actually at the time when we had donor, no donor issues. Right now in 2020, we do transplants with cohorts, haplos, unrelated donor with the 40 million people registry, and related donors, which are full 12 by 12 matches. So it's not an issue to me to find a donor today for identical bone marrow transplantation for AMLs. And we have significant number of desensitization protocols for the ones who have a high PRA activity. Even if the MFIs are 10,000, we have successfully desensitized those haploidentical transplants to go ahead with allografts. Now, one thing I want to point out in the intermediate, you have the FLT3 ITD allelic ratio. Now, this is tricky because most of the centers in the world do not do the FLT3 allele ratio. Practical point, if you don't have that, you would still refer them for transplantation, and I would do transplantation CR1. And I've been doing that at the largest center of Middle East as well for FLT3 because sometimes we don't have it. And suffice to say that 11% of the population in the world lives in European Union and the United States and Canada. And the 89% of the population is outside this. So that's why one has to look at the practical realities of the world and think of which AMLs to transplant, not to transplant. Now, that was only a tip of the iceberg, that slide. I hope you can see this slide, which is critically important because here is actually the overall disease-based indications for transplant. And one which should have on tips, in fact. One is complex cytogenetics. Do you need to look into the ELN classification details? The answer is no. Monosomies in CR1, monosomy 5, monosomy 7, a high intermediate base on ELN, I just showed you, relapsed or resistant to AML. Yes, now you got to choose it carefully because of the relapse risk post-transplant. Some of the cases, ultra high risk. That's what I discussed last year in the PSH meeting with Ghulam Mufti. That's what we were debating. That should not be referred, and I agree with them. AML arising from MDS or in CR1, you should transplant right away. For myelofibrosis, there's a lot of conditions, but yes, in general, yes. You should refer the patients to us, and we will definitely work to decide. Therapy-related AMLs, FLT3 ITD positive AML, as I mentioned, and certain leukemias. Biphenotypic, BPDCN, we're not going to go into BPDCN. We're just finishing a big study in CIBMTR in that, and biphenotypic leukemias, depending on the details of that. But suffice to say that a lot of these are actually, should be referred to the bone marrow transplant CR1, even before CR1, in fact, and then let the transplant teams decide. Now, the host factors are equally important because there are elderly patients who need a comprehensive geriatric assessment. And that's a tool we developed in New York when I was there, Strong Memorial Hospital. Supriya Mohili, Arthi, and other folks actually helped develop this. This is a very, very good scale to actually see which of the elderly patients will be fit for allograft, which will not be fit. We have had a lot of activity recently on elderly people. Muhammad Solar Index from Seattle is the gold standard since 2005, paper published in Blood, validated hundreds of times. Comorbidities, you look into that, and then congenital genetic factors as well. I look into this very closely because for many syndromes, Down syndrome, there's a totally different talk. But then this dyskeratosis congenita, a lot of things I need to look into this as well, that if they have AML, and if they definitely need a transplant. A lot of these cases refer to me, they have pulmonary fibrosis as a top problem, then I do not transplant them because they're going to die of lung toxicity. Solar index, just an FYI for the hematologists who don't do transplant daily, it's a gold standard, which we do every day, look in the PFTs and creatinine and all other factors, infectious disease, psychiatry. 15 variables, and then have a score. Score is above 3, then the risk is high of transplant-related mortality. Scores above 5, then I do not transplant these folks, irrespective of the disease status. Extremely rare, I have transplanted, yes, case by case. Depth of remission is equally important. So is there a disease in hematologic malignancies in which MRD is not important? The answer is no. Very few diseases MRD we don't do. We started with ALLs, as you know, precursor B-cell ALLs, but now AML is equally important. Conditioning regimen. I'm not going to go over the CTN0901, reduced intensity with myeloablative, which showed myeloablative was significantly decreasing the risk of relapse when we use MAC. And that's an important study published in JCO by Scott and colleagues, Rob Soifer, because the treatment actually, the trial needed to be stopped, in fact, early ahead of time because MAC was superior for relapse risk. GVHD prophylaxis regimen, donor factors, HLA age of the donor is very important. HLA haplo versus full matches versus 9x10, and then you look at the direction. Is it bidirectional, GVH or HVG? And this is what we do every day in our life, and KIRS and many other factors. Center effect is important as well in maintenance therapies. The environmental factors are equally important. Age of the host, expertise available, financial resources, access to care, family support, and patient expectations and goal. Now, is this as important as the genetics? The answer is absolutely yes. If the age of the host is extremely advanced and the insurance is not going to cover, in certain countries where they have socialized systems and they have a cutoff age of 70, for example, for allogeneic transplant, then you can't cheat the system. And anyways, I mean, there's actuarial life expectancy, which I'd love to talk about actually, because I do survivorship, but I'm not going to talk today. But you have to think about what age are we transplanting, what are the comorbidities, and what is the expected life expectancy, and what are the resources for the country if it's a socialized system. Expertise availability. If you have a wonderful transplant center in which you have the human resources who've done like 20 years of experience of autologous transplant, but not allogeneic, it doesn't help. You need a transplant facility which does everything. Financial resources of the patients are important. Access to care is critically important. Family support is not there. I mean, there's one person, he's 60 years old, coming to me for allogeneic transplant. CR1 needs the transplant for 3 ITD, but there's no family support. A divorced person living alone or 1 or 2 kids. Believe it or not, it happens much more frequently than we think it does in developing countries. Or the support is questionable. There's a lot of abuse or something else. We actually screen for PTSD. In fact, we screen for sexual, domestic, verbal abuse as well. In my clinic that we see allogeneic transplant consoles. How good is the family support? Because it's not the transplant. It's actually what happens after transplant that matters a lot. And what are the expectations and goals? What are you living for? I mean, you got to ask these patients, what's the ultimate goal? And you can get weird answers. In fact, you can get very good answers that you're living for this particular occasion on earth. You're living for this. You're living for a kid. You're looking for your parents. You're living for this, your spouse, or something else you want to achieve in life. So that must be documented in your notes clearly. This is the most important aspect that we miss quite often. Is there a graft versus host disease clinic in the center? Is there a survivorship clinic in the center, like long-term follow-up? Available post therapies for AML. It relapses, then what happens? You've got midostaurin, you've got sorafenib, you've got azacitidine, you've got second transplant availability, or absolutely no. You've got to discuss these things. You've got DLI availability or not. Is telehealth available? Because see, I'm going to give the message that this doing a transplant is like having a baby. 9 months of extreme suffering, and then you have the baby, which is a very laborious process called labor itself. And then what happens for the next 15 years? The amount of energy that parents put into it is the essential question you got to ask. And I'm more looking at this picture ahead of time because I'm biased towards survivorship, and that's what I do. So you have to think of when you see the patient first. And if you didn't think about these things, then you're looking at a disaster because it would start very well, but end in a disaster at the end of the day. And this is a reality that this is 2010 data from Alois Gratwal's paper from WBMT. In WBMT, we're tackling all the real world issues of transplantation. Now, you know, my curse is on Mongolia. There's a twinning project with China that started in Bangladesh, in Dhaka. 2 centers started. One started auto and the others started the allos in partnership with India, but also with Boston because MGH folks were there in Dhaka. In Nigeria, the transplant activity is going to start with the Italians and with our help, hopefully very soon. So we're looking at the world, looking at bone marrow transplant activity increase. So what needs to happen is you need to look into all the things that we talked about, the social circumstances, environmental, financial, long-term follow-up before you transplant an AML. Otherwise, you're doing a disservice because you transplant them and then what? You have to think about all these strategies before you establish a bone marrow transplant center. So the take-home message, I'm going to try to finish on time because it would require a little bit. I mean, I want to make sure that we're discussing things which are practical issues. Transplant is the only known curative treatment, potentially curative because it relapses in a lot of people, in most of the AMLs, not all. Within AML, CR2 versus CR1 matters a lot. And this is a slide I showed you. The ELN classification 2017, it's actually looking at it actually advising the high risks in CR1 to be considered for transplant right away. But in reality, it's actually every single AML in CR2 should be considered for transplant if the other conditions are met. Genetics, intermediate and high risk. Don't be confused about intermediate anymore in 2020. We're looking at transplanting these folks if we have all the post-transplant survivorship, GVHD facilities and expertise available, as well as the patient affordability is there, and the donor is identified. Host factors are important, age and comorbidities. That's a very important thing. I would ask you to look into the comprehensive geriatric assessment scales. And many of the scales are palliative medicine that we use. And social factors are an important role. Financial, insurance coverage, family support, access, telehealth, GVHD are the key here. So let me finish. I hope I'm leaving 3 minutes for discussion. I end my slides, a lot of them, with the picture of one of the greatest inspirations besides E. Donald Thomas from my academic world. And these are after my patients who died of allogeneic transplant and died of GVHD. And this is Shirley Nolan and her son Anthony Nolan, because of whom the world's first unrelated bone marrow transplant registry started in London. Well, with that, thank you very much, and I'd be happy to take any questions. Thank you.
I think we have a couple of minutes, so I'd actually ask a question that has come through. An anonymous question has come through.
Yes, I can see that question, and let me answer both the questions, in fact. Those are excellent questions. Can we do autologous transplants in these patients? And the answer is yes, we can. And there's a lot of data accumulating. Initially, we thought there were only a couple of centers in Europe that were doing autologous transplants, in Germany, one in Germany. And then obviously in Saudi Arabia, we have a huge experience in this. And the answer is yes. In selected cases who are not eligible for allogeneic transplantation, the long-term outcomes from the Italian studies, as well as some of the German studies, are showing almost equivalent results, but not in extremely high-risk leukemias because they relapse uniformly after autologous transplant. So unlike the American mentality where I trained in many institutions, Connecticut, New York, and Minnesota, where we have abandoned the use of autologous transplants. There is a significant role in some selected cases of AML, and these are not high-risk cases. So it's a good question, and the answer is yes, we can.
That's great. I think I have a question as well. In your second last slide, you were talking about family support and social support playing a very important role here because it's a long journey and it's a lifelong treatment. What is your comment on patients who have had history of non-compliance, for instance, going through their initial induction and consolidation? We do come across this situation where previously there is history of non-compliance with treatment and then they relapse. And obviously they become eligible for a transplant. Do you have any comments on that?
I have a comment, and this stems from my experience of hundreds and hundreds of patients that I've done allogeneic transplant upon. These kind of patients will, all of them will die in 6 months because what happens is even a little bit mess up with the immunosuppression after transplant with cyclosporin or tacrolimus or anything. They have the worst GVHD with the GI GVHD already admitted, and every single one of them unfortunately dies. So these are the patients, unless you have a social worker or a psychologist. If you don't have a psychologist, a board certified, that's fine. You need a social worker looking at these things in detail. compliance issues. And that's an essential checklist, just like PFTs. So I would not transplant these people because they have no idea what GVHD is. They have no idea what relapse is after transplant. They should not go into transplant. It's better to stay with the family and spend some time with them rather than doing this.
Yeah, I would totally agree with that. We've seen some horrific outcomes where sometimes you get pushed into doing something that you know will not end up very well. So I totally agree with that point. And in fact, in our center, we take it very seriously. And if there's any history of non-compliance, we'd rather not proceed with an allo transplant in that setting. So that's great. Thank you very much, Dr. Shahrukh. With that, I would like to invite our next speaker, who is Dr. Kaser Bashir. Dr. Kaser is an associate professor and program director of stem cell transplantation fellowship program in the transplantation and cellular therapy unit at University of Texas, MD Anderson Cancer Center. He has actually sent us his slides, so I would try to share them from here.
Which is 25%, will be fully HLA matched with the patient. 2 out of every 4 siblings, which is 50%, will be haplotype matches only. Biological parents and biological children always share an HLA haplotype with the recipient unless a rare genetic rearrangement has occurred. It is unlikely that any of the patient's parents, children, or first cousins will be full HLA matches unless the involved families happen to have a very common haplotype or there has been intermarrying among the families. Other potential haploidentical donors include half-siblings, aunts, uncles, nieces, nephews, cousins, or grandchildren. Now, the successful utilization of haploidentical transplants has significantly increased the available donor pool. Just to recap, every patient has 2 HLA haplotypes. These are located on chromosome 6. One set is derived from the father and one from the mother. For any given mother and father, there are 4 equally possible sets of HLA antigens in their children. Here is a family pedigree of the patient shown in red. The patient acquired the haplotype A from the father and haplotype C from mother. A haploidentical donor in this case is brother 1, who shares one paternal haplotype, which is A, with the patient and is mismatched for anywhere between 0 and 5 HLA genes on the unshared haplotype. The sister is the other haploidentical donor and shares one maternal haplotype, C, with the patient. Brother 2, on the other hand, is disparate and shares no haplotype with the patient. If you put this all together, we can see the trend here. The orange line here from the CIBMTR records show that the number of haploidentical transplants has significantly increased over the last 10 years, and it is now almost touching the green line, which is the matched sibling donor transplants. So what are the major advantages and limitations of haplotransplant, and under which scenarios one would prefer a matched unrelated or a mismatched donor? The major advantages with haplotransplantation include the near universal availability and rapid availability. As you may know, that the average time taken or required to find a full matched unrelated donor through registries is 3 to 4 months, and many leukemia patients do not have the luxury of that much time. Haplo donors, on the other hand, are readily available. Another advantage is high cell dose compared with the cord blood transplants. These transplants are usually cheaper since they do not require blood banking or big registries. Then donors are usually available for repeated donations for stem cell boost or donor lymphocyte infusions. The graft versus leukemia effect is robust, and as I said before, these type of transplants are not dependent on registries where certain ethnic groups are underrepresented. One disadvantage is intense bidirectional alloreactivity. Traditionally, the haplotransplants have been associated with high rate of graft rejection and high rate of graft versus host disease. Still, some scenarios exist where a match unrelated or a mismatch unrelated transplant is preferred. These include recipients with familial genetic syndromes, recipients who have very high levels of donor-specific antibodies to the family members, patients who lack living relatives or are estranged from their families, and of course, every now and then we run into adopted children who have no biological family members available. How do we select the haploidentical donor? The factors such as age, gender, parity in female donors, ABO blood type, and CMV status are more or less similar to what we use with other types of grafts. The incidence of CMV reactivation was higher with haplotransplant. However, many centers have adopted aggressive strategies, and with the availability of drugs like letermovir, that risk has largely been mitigated. On the other hand, donor-specific antibodies remain a major concern. We will discuss those in the following slides. Another consideration is NEMA, also known as non-inherited maternal antigens. And these are maternal antigens to which the fetuses are exposed during pregnancy and in turn develop a certain immune hypo-responsiveness, which later on in life, if used for transplantation, NEMA mismatches are associated with lower risk of graft versus host disease due to this acquired immune hyporesponsiveness during pregnancy. Another important factor is KIR mismatching, or killer cell immune globulin-like receptors. KIRs allow NK cells to recognize downregulation or absence of class 1 HLA molecules on the target cells, known as missing self. This phenomenon is usually observed in virally infected cells or cancer cells. Because KIR and HLA genes are located on different chromosomes, in an allogeneic environment such as after hematopoietic stem cell transplantation, donor cells that express an inhibitory KIR for an HLA class 1 molecule that is absent on the recipient targets can recognize and react to this missing self and mediate cytotoxicity. A number of institutions have established local guidelines to assist in the selection of donors with NK cell reactivity predicted by HLA or KIR genotype. This is something that needs to be developed institutionally. So far, there are no universal guidelines, but this is something definitely which should be considered. Donor-specific antibodies are a major concern with haplotransplants. The incidence is higher in Paris women and can be more than 50%. Nulliparous women also have a pretty significant incidence of DSAs. Male patients can also have DSAs, not as commonly seen as females. And again, patients who have had transfusions from allogeneic blood products can have a higher incidence of DSAs. It is not exactly known how do DSAs cause graft failure. The mechanism potentially involve antibody-directed cytotoxicity or complement-mediated cytotoxicity. As you can see in this Kaplan-Meier curve, if the graft failure develops due to these DSAs, that mortality is significantly high as compared to patients who do not develop the graft failure. Now, what exactly is the cutoff that should be used for detection and treatment of these antibodies? It is variable. It varies between different laboratories. However, the likelihood of graft failure increases with increasing MFI, which is increasing intensity of these antibodies. For example, if it can range anywhere between 9% for MFI of less than 5,000 to more than 50% if MFI is more than 5,000. Hence, DSAs should be checked in all patients at least 1 month before the transplantation. If DSAs are more than 1,000 at MFI, then and there's no alternate donor, then it is recommended that we should choose the desensitization. EBMT has developed detailed guidelines. Some of the strategies that are used for desensitization are listed in this table. For example, you have plasmapheresis, IVIG, monoclonal antibodies, splenectomy, eculizumab, etc. At MD Anderson, we have a protocol where we give 4 doses of bortezomib, then we do plasma exchange, IVIG, rituximab, and then just before the stem cell infusion, we use Buffycoat, which in theory can absorb those antibodies present in the donor graft. The goal should be complete removal of the DSAs, or at least bring the MFI to as low as possible. C1q is particularly dangerous. It is an complement setting antibody, and any patient who is C1q positive should not have Haplo transplant from that particular donor. Switching gears to the clinical component. Now, there are 2 famous platforms to use the stem cell haploidentical transplant. One is the T-cell replete, and the other is T-cell deplete strategies. Let's first discuss briefly the T-cell depletion strategies. T-cells depletion involves positive selection of CD34 cells or negative selection by removing CD3 positive and CD19 positive cells. The benefit of this strategy is that there's virtually no risk of graft versus host disease, and there's no need for immunosuppression after the transplant. But there are certain downsides to this strategy. First and foremost, that there's no selective depletion of alloreactive T cells. So while you're removing the T cells that can cause graft versus host disease, the T cells that react against infections are also removed, as well as the memory T cells. So this leads to high treatment-related mortality due to infection, which can be, in some cases, upwards of 35%. Also, since you're removing the immune surveillance, the risk of leukemia or other disease relapse is also higher. In order to address these, several strategies have been adopted. One of them is selective T-cell depletion, where alpha, beta T cells and B cells are removed. These are the cells that are geared towards graft versus host disease, but the gamma delta T cells are left in the graft to provide anti-leukemia and antiviral activity. Another strategy is the use of veto cells. This is based on the experience with the high-dose CD34 positive stem cell grafts, where it was seen that the megadoses exert an immunoregulatory effect. In other words, the veto activity, which facilitates graft activity directed against host anti-donor T cells. It's not only the CD34 positive cells, there are several other cell types which also have veto cell activity. In an ongoing study at MD Anderson, we are supplementing the T-cell depleted megadose haplotransplant with graft facilitating cells that can neutralize or tolerize the host anti-donor T cells and can potentially enable the engraftment following a non-myeloablative conditioning without any need for post-transplant immunosuppressive therapy. In this trial, the CD8 positive memory T cells are co-cultured with the donor dendritic cells and also pulsed with peptide mixture representing 4 prominent viruses, mainly EBV, CMV, BK virus, and adenovirus. These CD8 positive veto T cells can enable engraftment after a non-myeloablative conditioning and at the same time provide the antiviral protection. In this protocol, the conditioning involves 3 doses of ATG, fludarabine, and 3 grays of total body irradiation. 2 types of T-cell depleted grafts are infused. One is positively selected for CD34 cells, and the other one is negatively selected for CD3 and CD19 cells. The veto cells are infused on day 7. The aGVHD prophylaxis also involves post-transplant cyclophosphamide. We have treated several patients, and all patients have achieved engraftment, and the trial is ongoing. Now, the most common strategy for haplotransplants is the T-cell replete transplants. The 2 famous methods are so-called Baltimore protocol, or the post-transplant cyclophosphamide, or the GAIAC strategy, which is also known as the Beijing protocol. The GAIAC approach was developed at Perkin University. It involves 4 main components, which also prompts this acronym GIAC, G for GCSF stimulation of the donor, I for intensified immunosuppression through post-transplant cyclosporin, MMF, and short course of methotrexate, A for ATG, and C for combination of peripheral blood stem cells and bone marrow allografts. This strategy results in predictable engraftment and acceptable non-relapse mortality. However, the rates of graft versus host disease in the initial studies were higher, where grade 2 to 4 graft versus host disease was seen in approximately 36% of patients, and the risk and the incidence of chronic graft versus host disease was also more than 20 to 30%. The Italians modified this strategy, and they use anti-CD25 antibody, and the results show that the incidence of grade 2 to 4 graft versus host disease is down to 24%, and the chronic graft versus host disease incidence was down to 17%. Still, this strategy is not widely used outside of China. In the Western countries, including the United States, the most commonly used technique is post-transplant cyclophosphamide. As we all know, cyclophosphamide is an alkylating agent, and it is commonly given at a dose of 50 milligram per kilogram per day for 2 consecutive days, which is day 3 and day 4 after the transplant. How does it work? Aldehyde dehydrogenase is an enzyme that converts the active metabolite to an inactive metabolite. The donor stem cells are rich in aldehyde dehydrogenase. Tregs also show increased expression of this enzyme after allogeneic stimulation. In addition, the donor stem cells and memory T cells are quiescent early after the transplant. As a result, the memory T cells and the donor stem cells are spared the action of cyclophosphamide, which specifically targets the alloreactive T cells and sparing the stem cells and memory T cells, also the Tregs. So as a result, the incidence of graft versus host disease is decreased, while successful engraftment is achieved due to the sparing of the stem cells. Our institutional data shows that the T cell replete grafts are associated with better survival when done with the post-transplant cyclophosphamide. The immune reconstitution is also better with T cell replete grafts as compared to T cell depleted grafts, something that is expected. A little more on the immune reconstitution after haploidentical transplants. It remains an important issue. The major components of immune system include the innate immunity, which refers to the immunity that is present from birth and is not learned or adopted as a result of exposure to microorganisms. The adoptive immunity is accomplished through B and T lymphocytes that are continually refined and adjusted throughout the lifetime of the individual. The reconstitution of innate immunity does not differ much after haplotransplant compared to other donor sources. However, important variations in the reconstitution of adoptive immune system exist. This is a large study by Riola and colleagues that compared immune reconstitution after transplantation with different donor types. Post-transplant cyclophosphamide was used for haploidentical donors. They noticed that the median CD4 cell count at 100 days after transplant was 229 per microliter in the matched sibling donors. It was 190 after haplodonors, which was better than unrelated donors, cord blood donors, or mismatched donors. Since we have only 20 minutes for this talk, we do not have enough time to discuss the clinical results in detail. However, this table nicely summarizes the major clinical expectations with the haplografting. This is the meta-analysis of 30 studies, including more than 22,000 patients. It compared the outcomes of allogeneic hematopoietic transplantation using haplotransplantation with post-transplant cyclophosphamide and those from the other matched or mismatched adult patients with hematological malignancies. The summary is that non-relapse mortality is with haplotransplant is better when compared to unrelated donor or mismatched unrelated donor transplants. matched sibling donors still have better or lower non-relapse mortality. The risk of relapse, however, after haplografts is similar to the sibling donors and mismatched unrelated donors, but the risk of relapse was higher after haplotransplant compared to the unrelated donor grafts. So how to summarize all this? Matched sibling donor is still preferred. Haplo donors are definitely preferred over mismatched unrelated donors. Haplo versus MERD is a hotly debated question. Ongoing CTN trials are looking to answer this question. Last but not the least, relapse after haploidentical transplant is also a major concern. One of the common mechanism of relapse after haplotransplant is the loss of mismatched HLA, which can be seen in up to 33% of patients. This loss could be genomic HLA loss or downregulation of HLA. In this case, the DLI should be avoided. This cartoon nicely explains this. This patient's two HLA haplotypes are shown in blue and red. The first donor, which is depicted on the left lower side in blue and yellow, it shares a common blue haplotype with the recipient and a distinct yellow haplotype. At relapse, the leukemic blasts lose the mismatched red haplotype, which results in loss of the cell surface expression of mismatched HLA molecule. Now, once the remission is induced with salvage therapy, a second haploidentical donor is selected because they share the red haplotype with the patient but lack the blue haplotype. This will allow the second donor's immune system to recognize these disparate HLA molecules on the leukemic blasts to potentially elicit graft versus leukemia effect. So how do we choose therapy? If the mismatched HLA haplotype is retained, then DLI should be considered, keeping in mind the risk of graft versus host disease. Now, if the mismatched HLA haplotype is lost, then a second haploidentical donor from a relative who is HLA mismatched to the original donor should be sought, or non-transplant approaches should be considered. Looking forward, this is a nice summary of a survey conducted by CIBMTR about the predictions of stem cell transplantation. The first graph shows that most of the physicians predict an increase in the number of stem cell transplants performed across the country. This is the Western data, but we can extrapolate to other countries. The second graph shows that the most physicians think that haplodonors would be the second most preferred donor after the full matched sibling donors. And last but not the least, the post-transplant cyclophosphamide is expected to be the most common GVHD prevention regimen after the haplotransplants or transplants in general. In summary, the haploidentical stem cell transplant offers near universal availability of donors. There's no need for expensive donor registries or cryopreservation of stem cells. The risk of infection is high. However, results overall are similar to what are expected with the matched unrelated donor transplants. Haplotransplant provide a robust platform for immune manipulation, and the clinical survival results are not very different. Future directions are looking at several aspects of this form of transplantation. Their desensitization techniques are being improved. Strategies to minimize the relapse after transplant are looked at, and which type of haplodonor is better is also an area of active investigation. In the end, I would like to thank you for your attention, and I would like to acknowledge my colleagues and staff at MD Anderson Cancer Center. Thank you, and I hope you have a good rest of the meeting.
Thank you very much, Dr. Kessler. That was an excellent talk on haploidentical transplantation, something which in our part of the world we're going to see a lot more in the near future, as unlike the West, we don't have access to these unrelated donor registries. We'll take all the questions, I think, at the end. We'll proceed with the next talk. I would like to invite Dr. Saira Ahmed, Dr. Saira is an associate professor.
Dr. Saira is an associate professor.
And an inpatient medical director in lymphoma and myeloma. She's also outpatient CAR-T director in Department of Lymphoma and Myeloma and Stem Cell Transplantation at University of Texas MD Anderson Cancer Center. Thank you, Dr. Saira. I would invite you to share your presentation now.
Can you see my screen?
Yep, we can.
Perfect. Okay. So Kessler and Shaukat have done a wonderful job of kind of laying the groundwork for my talk. So I'm going to talk about graft versus host disease and kind of the general approach. So my learning objectives will go over the background and overview of GVHD, talk about acute and chronic GVHD, and kind of throughout the talk, we'll talk about therapeutic targets that have been emerging and newer agents that we are now use. So graft versus host disease is when the donor marrow cells mount an immune attack to the recipient, which causes GVHD. Now, patients can understand this as graft rejection, but actually that's not the case. This is the graft that's actually attacking the patient. There's a strong correlation between GVHD and graft versus leukemia or lymphoma effect, and we'll talk about that a little bit later. Acute graft versus host degrees up to any grade will be seen in up to 70% of patients receiving an allogeneic transplant. And frontline corticosteroid therapy for GVHD can fail in up to 40% of patients. When we talk about acute GVHD and chronic GVHD, it's actually a common pathway with different pathways that then lead to organ dysfunction. And initially, it is the conditioning regimen that allows inflammation and tissue damage that is then acted upon by T cells, active T cells and alloreactive T cells, which lead to the signs and symptoms of acute GVHD, which can be rash, weight loss, diarrhea, nausea, and hepatitis or hyperbilirubinemia. Chronic GVHD was previously temporally defined, meaning after 100 days of transplant. But there is significant overlap, and the time of GVHD is no longer used to define acute or chronic. The symptoms of chronic GVHD are different, where you have more skin changes that are associated with lichenoid changes and fibrosis, but there are other organs that are also involved far beyond kind of the GI tract and skin that's associated with acute GVHD. This is just a schematic of timing. So you can see from day 0 to around day 180 is your classic acute and late acute GVHD. But you can have chronic GVHD start as early as day 50, and kind of the average median time space where you see most folks have symptoms is between 1 to 2 years. And that also depends on the timing of withdrawal of immune suppression. But you can see that the curve goes all the way beyond to 5 years. So when we talk about the assessment and management of acute GVHD, you actually should start to think about this prior to transplant. So assessing risk for development of GVHD, and that is looking at both patient factors as well as donor factors and the type of transplant that they're going to have. Determining the prophylactic regimen that you're going to use. And then after transplant, making sure that you have the ability to identify signs and symptoms early to be able to intervene. Initially, generally, it's steroids that are going to be your first line of therapy. And then depending on response to steroids, you're going to add other lines of treatment. And this was briefly touched upon by Dr. Hashmi when he talked about having a GVHD clinic. And I think it's important because there are multiple people involved in patient care, and being able to assess signs and symptoms early, as well as getting pathologic diagnosis and tissue biopsies to help diagnose GVHD is very, very important. And that's where we look to our colleagues over here at my institution in dermatology and the GI folks who do endoscopy. Because really, we need them to be able to do these biopsies in less than 24 hours. And we have that kind of support, which is necessary for patient care. The overall goal of management of acute GVHD is to improve overall survival and decrease mortality, as well as overall to increase quality of life. Both acute and chronic GVHD greatly impact patients' quality of life, both in the short term as well as long term. And the greatest risk of having chronic GVHD is the prior experience of acute GVHD. We want to also minimize toxicity from both steroids and other agents, identify and treat infections, and above all, preserve GVL. So, as you further immunosuppress patients for treatment of graft-versus-host disease, you do increase their risk of relapse from their primary disease. As we were talking about assessing the risk of GVHD, your conditioning regimen plays a role in that. So myeloablative regimens, which cause profound cytopenia and completely myeloablate the patient to where they would have fatal pancytopenia without donor rescue, has the highest risk of graft-versus-host disease as well as treatment-related mortality. Reduced intensity regimens do cause cytopenia. They require stem cell support. However, generally they are of lower dose of either TBI or alkylating agent compared to myeloablative regimens. Non-myeloablative regimens are immunosuppressive. They're not myelosuppressive or irreversibly myelosuppressive, I should say. They do not require stem cell support. You will have prolonged pancytopenia. However, you will have reconstitution of your own graft after a non-myeloablative transplant. You may still have delayed graft-versus-host disease. And most importantly, tumor eradication depends on graft-versus-tumor effect. So while we prefer reduced intensity transplants or non-myeloablative transplants in patients who are older with comorbidities, these are not necessarily the best transplants for patients with aggressive disease who have a high risk of relapse. This is a schematic looking at the types of regimens that we would call myeloablative versus reduced intensity or non-myeloablative. And you'll see that you have much higher doses of TBI in the myeloablative subgroup, as well as alkylating agents compared to the non-myeloablative, which can be something like flu-TBI of 2 gray or flu-cy. Your immunosuppression goals, firstly, are to prevent graft rejection. You want to be able to eradicate the immune system of the host, and part of that it falls upon the conditioning regimen. You want to prevent graft-versus-host disease by suppressing T lymphocytes, and then you also want to decrease recognition of host cells as foreign. And there are numerous immunosuppressive medications that are used for this. And depending on the type of transplant, generally you're going to have immunosuppressive medications ongoing for between 3 to 6 months post-transplant. This is a schematic looking at very complicated pathways associated with graft-versus-host disease. Most commonly, you'll see on the bottom left cyclosporin or tacrolimus, which are calcineurin inhibitors, and have been used for decades for the prevention of graft-versus-host disease. More recently, sirolimus and everolimus, which are used either in isolation or in conjunction with a calcineurin inhibitor. And then mycophenolate, which impacts nucleotide synthesis, which by itself is a weak immunosuppressive agent, and most commonly is used in combination. But you can also see that there are multiple other pathways in which graft-versus-host disease can be impacted. And there are some agents that are still in clinical trials. There are some agents that have been tried in clinical trials and failed. And then we'll go further and talk a little bit about other agents that have shown efficacy. So at the root of graft-versus-host disease, you have to have T cells. If you don't have T cells, you're really not going to have GVHD. Unfortunately, though, GVHD equals GVL. So you need the T cells in order to have the GVL effect. So as we say that the T cells are the dominant cause of GVHD, most of the initial targets for prevention of GVHD were focused on T cells. So all of those drugs that we initially talked about, including calcineurin inhibitors, steroids, methotrexate, sirolimus, and MMF, we're focusing on the T cells after transplant. But there are other ways to actually selectively T cell deplete. And this was touched upon by Dr. Bashir when he was talking about the haplo transplants and T cell depletion. So that can be either gross CD4, CD8 depletion, or insertion of suicide genes into T cells, removal of alloreactive T cells with post-transplant cyclophosphamide, as well as other mechanisms of induction of Th2 type T cells, addition of regulatory T cells, and actually adding in NK T cells. So we'll move on to acute graft versus host disease. As we've previously said, there are the mainstays of immunosuppressive therapy, sirolimus, tacrolimus, and cyclosporin, methotrexate, and cyclophosphamide. ATG and alemtuzumab have been used for decades as well for T lymphocyte depletion. However, the flip side of using these agents are profound increases in viral infection post-transplant, and often leading to severe morbidity and even mortality. So as we choose the type of immune suppression that we're going to use, we also have to look at the patient and their risk factors for infection. Currently, the standard for GVHD prophylaxis is either post-transplant cyclophosphamide plus or minus MMF or a calcineurin inhibitor, or a calcineurin inhibitor with methotrexate during the time of conditioning. There are certain studies now that have shown post-transplant cyclophosphamide with very short courses of immunosuppressive therapy post-transplant, and there are certainly centers that use very shortened time periods of immune suppression to help increase GVL. Again, as we do this, we have to be wary of increasing the risk of graft versus host disease. Acute GVHD really looks at three organ systems. So skin in terms of a rash, and that the rash is graded as body surface area. Liver involvement, which is primarily denoted by hyperbilirubinemia, and then GI involvement, which upper GI involvement can be nausea, vomiting, anorexia, and lower GI involvement can be diarrhea all the way to severe denudation of mucosa, resulting in ileus or grossly bloody stool. At this time, the gold standard for treatment remains corticosteroids at high doses, and steroid refractory GVHD, by definition, is generally more than 7 days without any improvement in symptoms. Second-line agents for acute GVHD historically have been photopheresis, rituximab, thymoglobulin, pentostatin. And whenever you see a list like this, it means that there's really no standard. We'll talk a little bit about newer agents that have changed the dynamic a little bit in terms of choosing a second-line agent. Survival for patients with overall grade 3 to 4 acute GVHD has improved over the past 2 decades, and most of this is likely more associated with supportive care compared to a significant improvement in agents that help with treatment. So while you add a second agent, generally patients still remain on high-dose steroids, and the most common cause of death associated with graft versus host disease, and especially grade 3 to 4 acute GVHD, is infection, secondary to the profound immune suppression or relapse of disease. As you can see, that there's up to a 60% risk of death with the earlier cohort of patients that has come down to 40%. But again, these are not great numbers, and we have a long way to go in terms of improving the outcomes of patients who have grade 3 to 4 acute GVHD. The newer therapeutic agents for acute GVHD fall between both treatment and prevention. So ruxolitinib received its breakthrough designation in 2016 based on a multi-center retrospective study looking at steroid refractory acute GVHD, and it has become part of the treatment paradigm for the treatment of acute GVHD. And generally, this is the first agent that we will add on in steroid refractory disease. Post-transplant cyclophosphamide was explained very nicely by Dr. Bashir. And it is being used not only for patients receiving haploidentical transplants, but also now there is generally a switch to use it for both matched unrelated and matched related transplants, both with myeloablative regimens and reduced intensity regimens. As you can see that it decreases acute GVHD and chronic GVHD. Some of the early data was a little bit hard to interpret because generally haploidentical transplants were where post-transplant cyclophosphamide was first used, and those transplants initially were marrow only. But as we've moved to more peripheral blood, as well as other types of donors, we've seen that post-transplant cyclophosphamide has indeed held as an improvement in terms of the incidence of acute GVHD and chronic GVHD. Vorinostat has also been shown in prospective studies to be incorporated within the conditioning regimen and to decrease the risk of acute GVHD. And interestingly, it seems to prime the T cells to perhaps be more to better the steroid use. So you can put on corticosteroids after vorinostat and actually have improved outcomes and improved sensitivity to steroid use. Bortezomib has also been used in combination with cyclophosphamide as well as in combination with tacrolimus and methotrexate, and has also shown a decreased incidence for acute GVHD. Moving to chronic GVHD, this is an extremely complex biologic phenomenon with multiple phases. So you have your acute inflammation and tissue injury, which has a cytokine storm associated with it, with vascular inflammation. And this is primed in the time period where you have the evolution of acute GVHD. And then this, for some patients, will move on to a chronic inflammation. So not every patient who has acute GVHD will progress to chronic GVHD, but those that do have thymic injury and dysfunction and have a deranged kind of panel of regulatory cells. And eventually there is a phase 3 where you have aberrant tissue repair and fibrosis. And that's where you see TNF alpha and IL-17, as well as an abundance of macrophages and fibroblasts. The kind of schematic here is showing the complex interplay between all of these cytokines and how difficult it is to kind of cut off one pathway and arrest chronic GVHD, because there's so many innate coexisting pathways that lead to ultimately symptoms of GVHD. Organ involvement for chronic GVHD can span cutaneous, oral, liver, eye. You can have chronic GI involvement, lung involvement, esophageal, and joint. As you can see, most commonly it's mucosal areas that are predominantly involved. However, this is profoundly, part of a patient's life and greatly decreases their quality of life. And so when we talk about long-term outcomes and survivorship, chronic GVHD really does play a huge part in that conversation. The Global Severity Index for chronic GVHD is a scoring method, and it's looking at both the grade, mild, moderate, or severe, as well as the organs involved. In order to have a diagnosis of GVHD, you either have to have one diagnostic manifestation of chronic GVHD or one distinctive manifestation plus a pertinent biopsy finding. And this is the NIH criteria. These are just some pictures of patients who have chronic GVHD, and as you can see, this can be very severely debilitating for a patient to have to live with these kinds of disabilities over a long period of time. And again, these patients are not only on immunosuppressive therapy, but they're also on often chronic corticosteroids. So when we talk about the mechanisms to prevent GVHD as well as the treatment of chronic GVHD, Again, we go back to how do you better engineer your stem cell graft or help prevent GVHD, and that can be with the addition of ATG, post-transplant cyclophosphamide, CD34 selection, ex vivo selective T-cell depletion, or donor IL-2 therapy. There has been some enthusiasm for adoptive T-regulatory therapy, and then B-cell depletion in vivo using rituximab, ofatumumab, obinutuzumab, which is not really shown to be as good of a way to prevent GVHD as was once thought. In terms of treatment, there are other pathways that have been found, including the BTK pathway and the ROCK2 pathway. There are other Treg sparing therapy, which includes sirolimus, MMF, ruxolitinib, bortezomib. And again, you can use ECP photopheresis and low-dose IL-2. Second-line chronic GVHD, it really is, again, a number of different agents that can be used. There are multiple retrospective and a few prospective studies which show high response rates. But again, the studies are varied in their design, and oftentimes the results of those are hard to really interpret. Most physicians will choose second-line therapy based on patient preference, need for monitoring, risk of toxicity, ongoing infections, and other organ dysfunction that may increase the risk of complications. Just as I said before, when you have a list this long of agents that could be used for treatment, it means that nothing is really a home run. And this is really kind of just an overview of how patients are put on different agents and how clinicians choose what they're going to use. And steroids are still part of your mainstay of treatment, and often the dose will go up and down depending on the flare. So when we select GVHD therapy, the clinical efficacy, the toxicity profile, the mechanism of action, those are all important. But what I would also say is the mode of delivery is very important. Treatments such as ECP, which require a great deal of financial support, both in terms of institutions having to invest in the machines, as well as IV access, is not necessarily feasible for not only all institutions, but all patients to have to come and go several times a week for several hours. IV infusion is some medications only pathway to be able to be used. Others are injections and others are pills. Some require a great deal of monitoring. Sirolimus and tacrolimus, when used together, have an extremely high risk of complications, including TMA, and for that reason have to be tightly controlled and require patients to get multiple laboratory testing, sometimes twice a week. At the end of the day, patients have to be compliant, so they have to be able to take the medication and the type of treatment that will control their GVHD. And ultimately, cost is a big driver in all of this. Thank you. Any further questions?
Thank you, Dr. Saira. I guess we have a couple of minutes before the next presentation. So we'll take questions at the end, but I have one question particularly. So as you know, most of the GVHD preventative immunosuppression is calcineurin inhibitor based. We occasionally do come across patients who pre-engraftment develop renal impairment. What do you do in that situation where we're unable to use calcineurin inhibitors?
Yeah. So oftentimes we will use sirolimus, more the mTOR inhibitors. And I think that, post-transplant cyclophosphamide has also really changed the way that we look overall at GVHD prevention, because it can be used in a number of, patients who otherwise are unable to take long-term calcineurin inhibitors. On the flip side of that, though, I think that, as we start to choose patients for allogeneic transplant, renal failure is one of those things where you hope that it turns around, but if it doesn't, it overall early in transplant can lead to a higher risk of morbidity and mortality because of the other medications that often have to be used, including antivirals. But if we have a short time where somebody has a transient acute renal failure, often we'll switch to either a post-transplant cyclophosphamide type paradigm or use sirolimus.
That's great. Thank you very much, Dr. Sarah, for a great talk. It was a big topic, but you have tried to cover it in a comprehensive way. Thanks a lot. We will move on to our final presentation for this session. I would like to invite Brigadier Dr. Kamrunisa Chowdhury. Dr. Kamrunisa is a consultant hemato-oncologist at the Armed Forces Bone Marrow Transplant Center in Rawalpindi, Pakistan. Thank you for joining us, ma'am. I would invite you to share your presentation, please.
Is the screen on?
Yes, we can see it. Yep.
Okay, thank you very much. So, Assalamu alaikum, everyone. Thank you so much, Dr. Usman. And I'd like to thank the organizers for inviting me, of course, to share our experience here. So I'll be talking about autologous transplant in multiple myeloma. In the end, I will be showing you some of our own work. Okay, so we know that myeloma has come a long way, and we have moved from where it was a fairly rapidly fatal disease to a disease that patients can live with for many years, although they keep on relapsing. And we are closer than we ever were to a point where we do see that some patients may achieve a cure in some time in the near future. So a lot of this is due to the multitude of new drugs that have come in over the last decade or so. And they coupled with our increased understanding of the biology of the disease, this has resulted in improving overall survivals. And in fact, the patient's lifespan has increased several-fold with these new strategies. So the newer drugs, which are the mainstay of treatment now, the immune modulators, immune modulatory drugs, and the proteasome inhibitors. They came in the earlier part of the last decade. Now we have the monoclonal antibodies, more recently the CAR T cells, and a host of newer antibodies, antibody conjugates, bispecific engagers, etc., that were presented at the ASCO as well, and that are in many of which are in the process of approval. But what we do continue to see as well is that the central role of transplant as a standard of care still exists. And we see that in data from both major registries, the CIBMTR and the EBMT, where we see that the autologous transplants for multiple myeloma have been increasing, and in fact, they have overtaken lymphoma as the single most common indication for autologous transplantation. So when we're looking at the treatment for a newly diagnosed patient, the two major factors that impact our decision, number one is whether they're transplant eligible or not, and number two, what group of risk they occupy, whether they're high risk or standard risk. So this is a rather busy slide. We're looking at the summary of phase 3 clinical trials that have evaluated the efficacy of autologous stem cell transplant, and most of these trials have shown a progression-free advantage. The earlier trials showed an advantage of about a year or so in the overall survival as well. However, the problem with the earlier trials, of course, is that many of these trials, some of which were before, in fact, the novel drug era, and even these earlier trials, you can see that most of these earlier trials have used only one or the other of the immunomodulator or the proteasome inhibitor. Out of the recent trials, this is the IFM part of the collaborative trial between IFM and the Dana-Farber Institute. And what this is, they had 700 patients who received the current triplet, bortezomib, Revlimid, dexamethasone, and half of the patients went on to get a transplant, and the other half received more cycles of VRD. And what they were able to again show was a significant advantage for progression-free advantage for the transplant arm versus the non-transplant arm, although there was no advantage in terms of overall survival. And more recently, we have the KRD, carfilzomib, in combination with either cyclophosphamide dexamethasone or with lenalidomide dexamethasone, and followed by transplant. And although earlier results did show that there was comparable results in terms of the response rate as well as attainment of MRD negativity between the transplant and the non-transplant arm, but later updates have shown that there is a significant advantage in terms of progression-free survival for patients, for high-risk patients who received transplant. So this is the data from the IFM study, and we see that the advantage in terms of the progression-free survival could be seen across all groups in terms of age, the type of multiple, in terms of the type of multiple myeloma, the ISS stage, or the cytogenetic risk stage, all favoring autologous stem cell transplant. What about tandem transplantation? And the data on tandem transplantation are less clear. So here we have three clinical trials. The first one is in the first row is a pooled analysis of 4 randomized controlled trials. And what they were able to show was a progression-free survival for patients who underwent a tandem transplant compared to patients who did not. However, the problem with this particular study is that the patients only receive bortezomib-based regimen as induction, and it's not a randomized study. At the bottom of the table, we can see these data that again compare a single versus a tandem transplant, and here you can see that I'm sorry. And here we can see that again, there is a progression-free survival advantage, 73 versus 64 at 3 years, although the difference in terms of the overall survival is not so impressive. And this study, again, there's a problem. They used only one of, they used bortezomib as the plus cyclophosphamide dexamethasone as the induction, and they did not use lenalidomide upfront, although it was added in the consolidation. The patient received the consolidation and they did receive lenalidomide maintenance. And lastly, we're I hope there isn't a problem with the screen share. Dr. Swan, can you see the screen, please?
Yes, we can see your screen, but we're still on the tandem transplant screen.
Okay, thank you. Okay, so lastly, we look at this study in greater detail in the next slide, and this is the long-awaited BMT-CTN trial. They looked at more than 700 patients. These patients received different induction regimens depending on the physician preference. All of the patients went on to receive an autologous transplant, and then they were randomized to either lenalidomide maintenance or VRD consolidations followed by lenalidomide or a second transplant followed by maintenance. And the analysis showed that actually there was no difference between the three arms. And this was an intention to treat analysis. So when they looked at it again in terms of the treatment that was actually received by patients, there did appear to be an advantage to the tandem transplant arm. And this was particularly true for patients who were in the high-risk group. And although there are some problems with the way the high-risk group was defined as such. So coming to whether we can or we should be offering transplant upfront or once patients relapse, and this is a pertinent question given that patients do not actually have an overall.
Sorry, Dr. Kamrunisa, we can't hear you very well. The voice quality has changed a bit.
Okay, so can you
I
hear
think
me
it's
better now? A bit louder?
slightly. It's a bit better now. Yeah, you can continue.
Okay.
Yeah.
I'm sorry, I think there's a problem with the internet connection. So, so coming to whether we should transplant patients early or the transplant can be delayed until disease progression. And this is a relevant question, considering that obviously there is no overall survival advantage. And these again are the data from the IFM trial. And what we see is that patients in this study, half of the patients received transplant upfront after RVD induction, and the other half went on to receive more cycles of RVD and were transplanted at relapse. And what we see on the overall survival panel is that there was no difference between the two groups, although about 80%, actually 79% of patients who were in the non-transplant arm at the beginning did eventually receive a transplant. But when we look at the progression-free survival, we see a distinct advantage, 50 months versus 36 months for patients who ended up having a transplant and who had a transplant as the upfront treatment versus patients who received it on progression. So based on these and other data, upfront autologous transplant is recommended for all eligible patients. It's easy to do a transplant at that period in time, this is a treatment that is going to allow for the longest period of remission. Delays can, however, be considered, of course, for patients who do not opt for a transplant at the very beginning. But this would be preferable for patients who are standard risk and who have achieved a very good partial response, at least, to the induction chemotherapy. And there is, of course, the risk because.
Sorry, Dr. Kamrunisa, again, can you adjust your mic? Your voice is changed again. Yep. Try again.
Okay, I'm sorry. So I hope this is better. Are we any better now?
Yep, you can continue. Yep, it's just with the mic, I think, on your end.
Okay, so obviously we know that myeloma is a disease of the elderly, so there is this risk that patients may not be suitable candidates for an autologous transplant at the time when they relapse. And in fact, there is this retrospective analysis in which they looked at the reasons for patients not being able to go on to transplant, and these included newer comorbidities, deterioration in the functional status of the patient, and about 10% of the patients eventually actually did not have a second transplant at relapse. So the current practice would be an early referral to establish eligibility, and we know that patients, when they come in for treatment for myeloma, many of them are quite unwell, so the fitness needs to be assessed later on as well to see once patients respond to treatment, they tend to become better and to be in a fitter condition to undergo transplant. And the two major issues that we have in this group of patients is their age and their renal function, but we have some data to show you, and here you can see this particular study in which they looked at older patients. Most studies have looked at patients who are younger than 65 years, of age, but here we're looking at two subsets of patients, 65 to 70 and patients younger than 65, and we see that there is no difference in terms of both the progression-free survival and the overall survival, although they did have a slight, few more problems with the older patients. And again, a registry study from CIBMTR, they looked at a very large number of patients, more than 2,000 who were aged more than 70 years, and they found no difference in the non-relapse mortality or the progression-free survival when they were compared with younger patients. So coming to the renal disease, and this very nice data sums it up. We have patients who may have mild disease, moderate or severe renal disease at the time of presentation, and once they're taken to transplant, we see by these very nice curves that there is no major difference between the three groups of patients in terms of overall survival or the progression-free survival, although both of these did not reach statistical significance. So I will be just touching on this, the optimal initial therapy and the number of cycles. So generally 3 to 4 cycles of a proteasome inhibitor-based triplet and immunomodulatory drug. One should avoid melphalan, of course, because of the damage it can cause to the stem cells, and immunomodulatory drugs, particularly lenalidomide, has a similar problem, so patients should not be on it for more than 4 to 6 cycles when stem cells are collected. So a quick comparison between carfilzomib and bortezomib as the induction regimen, and we see this comparison from Shaji Kumar and his colleagues. And this is the endurance trial, which was again presented at the ASCO this year. And we see that there is actually no difference in terms of the progression-free survival. And this was a surprising finding, in fact, between both the VRD and the KRD arms. So what should the response goals be before you take a patient to transplant? And unfortunately, there are no randomized data that would show us the number of cycles or the depth of response that is required before we can take patients to transplant. But of course, the goal is to achieve the best response that we can before transplant, because we know that deeper responses are associated with a prolonged progression-free survival. However, although we do not have randomized data, cohort-based studies have hinted that post-transplant responses are in fact more important. So any patient who achieves some degree of response to the induction therapy can be referred for autologous transplant, except of course for patients who possibly have progressive disease. So again, here you can see that in terms of the TRM, relapse, progression-free survival, overall survival, there is no difference between patients who did achieve a very good response to the induction chemotherapy and patients who did not. So the stem cell collection for multiple myeloma autologous stem cell transplant, and we are, almost everyone is now using PBSCs, and you can use GCSF with or without cytotoxic chemotherapy, and patients who are at risk of failure, we use Zika. The minimum CD34 cell dose is 2, although lower doses have resulted in engraftment, and the target would be to collect enough stem cells for more than one transplant. So if there's a need for a second transplant, that can be offered. Coming to the conditioning regimen, high dose transplant.
Dr. Kamrunisa, can you please check your mic again? Your voice quality has changed again, so.
I think that's mainly to do with the internet connection.
Yep. Okay, that's fine. You can continue.
I'm so
yep.
sorry, but that's mainly to do with the internet connection. Okay, so
it's better now, actually. Yeah.
I think it comes and goes. So coming to the conditioning regimen, we know that high-dose melphalan is the standard of care, and that was after studies in the early 2000s showed that high-dose melphalan 200 milligram per meter square was superior to 140 milligram combined with TBI. Because of the synergistic effect between bortezomib and melphalan, there have been studies using both of these as conditioning regimen, and as we've also had studies with busulfan, melphalan, bortezomib, and bendamustine and other drugs, and there are promising results from many of these recent studies. And I'm going to be talking about this particular study that was published by Dr. Kasser Bashir and his group at the MD Anderson. And this is a recent update from this particular study that was published in the Blood Advances last month. And what they have been able to show is that busulfan combined with melphalan as conditioning regimen in multiple myeloma leads to better progression-free survival, although the overall survival benefit is not so evident at the moment. So the only trial which has looked at multiple myeloma relapse and the role of autologous stem cell transplant is the UK Myeloma 10 trial. And we see here that there is an advantage to using autologous stem cell transplant in terms of progression-free survival, although again, the overall survival is not affected so much. But this was particularly useful in patients who had a late relapse, more than 12 to 18 months after the first transplant. So coming to the conditioning regimen, what is the role of conditioning? And we did see the stamina trial, and we did see, and similar trials have shown that there isn't any reasonable role for post-transplant consolidation. And these are the results of one of the tables from the stamina trial. And we do see that the consolidation treatment does not really make a lot of difference to the progression-free survival or the overall survival. So consolidation, not routinely recommended. It can be used in the context of clinical trials or in high-risk patients, and it can be offered, of course, to patients who are not willing for maintenance, and you would have to give at least 2 cycles in that scenario. So post-transplant, the recommendation is for lenalidomide, and generally we are able to start lenalidomide by day 90 for patients who are in the high-risk group. Proteasome inhibitor-based maintenance with or without lenalidomide is generally recommended, and we see the evidence for the maintenance here in this slide, where this is a meta-analysis, and we can see several studies here, and all of these studies show that there is a progression-free survival advantage that favors lenalidomide maintenance. And this advantage holds across different age groups, different all the ISS stages, and the in terms of the response that the patients had after stem cell transplant. So the duration of the maintenance treatment, and different authors have used maintenance for different periods of time and different investigators, and so in some of the studies we do see that maintenance has been given for 1 year. So these are the results from the BMT-CTN 0702 trial, that is the stamina trial. And they gave maintenance for 3 years. It was extended later on. And what we see here is that patients who stopped maintenance at 3 years had an increased risk of relapsing as compared to patients who continue to take the maintenance even after 3 years. So generally, the recommendation is to continue maintenance until progression. So this brings me to our own experience, and I'll begin by telling you how we do things here. So we do have the investigations to make the diagnosis. A couple of years ago, we had the availability of the FLC analysis, and very recently, a few months ago, the myeloma FISH panel has been added so that we can do cytogenetics to see risk assessment. Radiology is available. A couple of years ago, PET-CT became available to all of our patients. So
Dr. Khanum is just saying we have 2 minutes left.
Okay, so we are using the same, usually recommended induction chemotherapy, and taking patients through transplant who achieve the best possible response, generally less than 65, but we've taken patients who are older. So we'll just go quickly through the challenges that we have. So there are, of course, delays in diagnosis and referral, of course, financial constraints and lack of diagnostic facilities because these are not widely available, and FISH is available only in one lab, free light chain ratio in only a few of the bigger labs. And a major issue is that most of the myeloma drugs are imported or smuggled, and of course there is that concern about their, whether they work or not. There is a limited availability of novel drugs, and there are wide differences in the practices in the country and the referral of patients for transplant. And lastly, and most importantly perhaps, there's a very small number of transplant centers which are actually saturated to capacity as ours is by benign disorders like thalassemia and aplastic anemia. So very quickly coming to our data, and here you can see the patients. We have 152 patients data here, and these patients, the age range was 28 to 85 years. The median age was 58, and most of these patients have stage 3 disease, and they were given multiple types of induction chemotherapy. So these are the patients who underwent transplant, and we were 36 patients, a rather small number. Most of these patients we've been able to transplant over the last couple of years only, and in fact the median follow-up is only 17 months for the transplant rate. And what we've used is Melphalan 200 for the conditioning regimen. And these are the overall, so this is the overall survival, 65.7%, and the follow-up is for median follow-up is 44 months.
Dr. Kamranissa, we're over the time limit. Do you mind just wrapping up the talk?
Yes,
yep.
This is the last slide actually. So the last slide is of the progression-free survival, and the follow-up is short. So, but we still have an advantage. With progression-free survival of 51.2% in the transplant arm. So I'd like to thank you. Sorry about the internet connection, and thank you for your attention. I hope you did manage to get most of the presentation. I'll be happy to answer questions.
That's great. Thank you very much for a great talk. I would ask Dr. Bushra to start the question and answer session, if you can, please.
Thank you very much. Can you hear me all?
Yep, we can.
Okay, so thank you to all the wonderful speakers, first of all. It was a privilege to have your valuable talks. I really appreciate that you took time out of your busy schedules, particularly for the speakers from America who are joining on a Saturday night, and also early Sunday for the locals, as well as from for Dr. Shahrukh in Abu Dhabi. So thank you very much once again. So Dr. Saira, I have a question for you. You know, you've mentioned about steroids and GVHD, and yes, steroids are wonderful things. And you did mention about lots of other agents for immune suppression working at different levels. But from practical point of view, what is your choice of immune suppressive agents other than steroids in steroid refractory cases?
So I think, generally now for steroid refractory GVHD, ruxolitinib has shown to be most useful. And that's generally the first agent that will start after we kind of have the steroid refractory acute GVHD. In chronic GVHD, that often will be, again, our first choice, plus or minus photopheresis, or other agents, including sirolimus or Velcade, ibrutinib. So in chronic GVHD, you have a few more agents that you may reach for, but generally for acute GVHD, ruxolitinib is our first choice after steroids have failed.
Okay, thank you. And Dr. Kasser-Bashir is not here, but I might ask you a question that we wanted to ask him. He mentioned about the use or not to use DLI after Haplo transplant, since we will be having, probably we'll be having a lot of Haplo transplants here. So in your practice, how safely do you give it? How often do you give it? And what are the doses or precautions, suggestions regarding its use?
So I think, he had one slide in there that was very nice in terms of when to use a DLI and looking for kind of HLA loss. And so I think that's really important because if you give a DLI in that particular situation, you're increasing the risk of graft versus host disease without actually improving the outcome of disease. However, outside of that situation, kind of the first rule of giving a DLI is make sure the patient doesn't have any ongoing GVHD requiring immune suppression. And then in terms of, the timing of DLI, you usually go up with the dose, and different centers will do it differently. But, at our center, they'll usually do it once every 3 to 4 weeks, increasing doses of DLI. And really, I think part of it is looking at the patient and the risk of graft versus host disease. And so I think that, when Dr. Hashmi said having these kinds of conversations, oftentimes patients, really want to have disease control without understanding that graft versus host disease can be an extremely traumatic side effect. And so it's always a risk versus benefit type situation. And especially in DLIs, oftentimes it's refractory disease, and disease that's refractory after an allogeneic transplant, depending on what it is, right? CML is a very different disease than large cell lymphoma. And so understanding that DLIs have a certain effect in some diseases, while in other diseases, the possible benefit is quite low.
Okay, thank you. We have a few questions. Any of the panelists can actually answer. There's a question regarding if there is any post-transplant maintenance therapy trial ongoing at any of your centers. I guess they're trying to ask regarding FLT3 inhibitors probably. But that's a question for one of the doctors from Karachi. Dr. Saira, any?
Yeah. So I'll answer. We have certainly a number of trials going on, including post-transplant azacitidine and other oral agents. But I think FLT3 inhibitors, specifically as you mentioned, or post-transplant tyrosine kinase inhibitors have already shown benefit. And generally, we are putting patients on those agents if they have those particular mutations post-transplant.
Yes. And there's another question that if we go for tandem transplant, what should be the time duration difference from the first transplant? That probably will be for myeloma. I'll probably be more relevant. Dr.
Yes,
Kamrunisa?
Yes, of course. So generally you would want to go on to a tandem transplant within about 3 to 6 months. So that would be the appropriate time. Because later on then I don't think it's going to have the same kind of advantage that you would.
Yeah, and in your center, are you practicing this? tandem
No,
transplant?
in fact, no, we haven't. In fact, we are, as I said, we did not have cytogenetics at the FISH panel until really a couple of months ago. So, but we are planning on a trial to do tandem transplants or to increase the conditioning intensity for patients who are in the high-risk group. Now that we do have that, facility available.
Okay, thank you. There's one last question that was that was directed towards Dr. Sharik Hashmi, but he's not here, I think, because he used to join in for the next session as well. But I'll put it forward that considering that, oh, you're here, so good.
Yeah.
So Dr. Sharik, so as you said that for AML, practically anybody who has AML can be eligible for a transplant. For a high risk and an intermediate risk one particularly, they are transplant eligibles. In our settings here in Pakistan, where on one hand you have an advantage that there are lots of siblings, so you might find a fully matched sibling. But on the other hand, if you don't have a fully matched sibling, then you do not have a voluntary matched unrelated sibling. So in that scenario, if you have a haplo, for example, for intermediate risk transplants, would you go for haplo for all of them? Obviously, considering the other disease and host-related factors.
Yeah, sure. Well, I'm in the clinic right now, so I'm sorry for the mask, but the answer is yes to the question. If intermediate DLN risk, if you've got a haploidentical donor without significant increase in antibodies, and all those things are taken care of, MFIs are less than 1,000, and you have no 12 by 12 match sibling donor, then it's totally reasonable to go for that. And in fact, that's what we're doing. As soon as we identify no sibling match, we prepare for haplos, so unrelated registry, and rapidly work on that.
Can I ask one question, Dr. Brescia, as well?
Yes, of course.
Dr. Shahrukh particularly, and Dr. Saira may chip in as well. So basically, you showed the ELN sort of risk categories for AML. Amongst the adverse risk group, we have these very adverse risk patients as well, including the P53 mutated ones and complex karyotype ones. And some studies show that even with allo transplant, the outlook is extremely poor. So what is your take on that? Would you still offer an allograft for someone with, very adverse risk acute myeloid leukemia with TP53 mutation?
Well, Sarah, you want to go ahead? You want me to?
So I think, again, a part of it is talking to the patient and risk versus benefit, right? So age comes into it, other comorbidity status comes into it, but at our center, we would still offer transplant for P53 mutated complex karyotype if you would have the right situation, because there is a small proportion of patients who will have benefit, even with those bad adverse kind of effects.
Yeah, I would like to concur with that, that in very selected patients, if we have a mitigation plan, for example, post-transplant maintenance therapies or escalated DLI already planned in the regimen for the next 6 months, then I think it's reasonable to consider that. The Cleveland Clinic folks initially did the first single-center study in which they looked at ultra-high-risk AMLs with complex cytogenetics and monosomies and P53, and the relapse risk over 2 years was above 90%. So it begs the question that should you do that or not? In CIBMTR, we did the studies in complex cytogenetics, and we actually found out that in 5 years, unlike single center, because we've got a lot of data in CIBMTR, 5 years, majority of them will relapse, and the mortality is extremely high. So extremely selected cases, I would still consider transplanting, very young pediatric, in which I can actually do something after transplant, because the relapse is imminent, almost imminent within 2 years, if not 2 years, and within 5 years. Most of them happen within a year. But yeah, case to case. But in general, I do not transplant these folks unless it's very, very young people with excellent health, and I have a mitigation plan.
Okay, thank you very much. With this, we wrap up. This was an excellent session, I think. We really enjoyed it. Thank you very much for being with us and for taking time on a weekend. Thank you, Sarah. Thank you, Dr. Shark. Thank you, Dr. Kamar.
Thank you very much. Thank you.
Thank you.
Take care. Bye.